Hi everyone, my name is Jenny Niedenfear. I'm a current PhD student at the University of Texas Health Science Center, and I conducted this review to evaluate and synthesize the existing literature to determine which theories and constructs have been the most salient in promoting exercise adherence among older adults with osteoarthritis. So osteoarthritis is a chronic joint condition that affects the quality of life, mobility, and overall physical functioning. It affects at least 32.5 million adults in the United States, while incidence increases with age. Patients that adhere to physical therapy have improvements in their physical functioning and pain symptoms, but there are also many barriers that limit adherence, such as fear of pain and lack of social support. There's also limited research funding and involvement from governmental organizations for osteoarthritis patients. So my search strategy was performed in PubMed with a mix of relevant keywords and mesh headings. After performing a rigorous inclusion-exclusion process and finding initial references through backtracking sources, I ended up with a total of 36 papers in my analysis. So I analyzed several theory-based interventions. So the TPP showed the most significant impact on exercise adherence among 4 interventions, with the 4 TTM interventions focusing on action stages like maintenance generally had weak effects, except for one that achieved 48 weeks of adherence through the stratification of the participant stages and targeted behavioral processes such as dramatic relief and consciousness raising. The SDT interventions also increased self-efficacy and outcome expectations, but did not improve exercise adherence due to the severity of participants' osteoarthritis, and this is a significant barrier for this patient population. The most salient constructs are self-efficacy, perceived behavioral control, outcome expectations, behavioral beliefs, and decisional balance, which surround the confidence and ability, and also the positive and negative expectations of adhering to an exercise regimen. Social support and normative beliefs are less salient among older adults, specifically because people at this age need less social support for exercise behaviors. Strengths of these theories include their applicability to populations with other chronic conditions, as they are empirically supported across many populations. However, there still is limited operationalization of the constructs or lack of precision and measurement. Not all the constructs were measured in some of the interventions. So to address this gap, evaluating all the constructs in each theory can best guide researchers in predicting the factors that are associated with or lead to adherence. Future research should work to develop long-term interventions while considering multiple levels of influence to evaluate exercise adherence. So to conclude, no single theory is going to be able to account for the barriers that older adults encounter with their osteoarthritis. Applying core constructs from each of these theories that facilitate confidence, improve attitudes, and positive outcome expectations will be beneficial in enhancing health outcomes and improving adherence for this target population. Thank you.